Dr. Wolski, many patients, when they have, let's just say the knees hurting or the back or the neck, pain is unbearable, and we hear very, very often, very fast. I see it on my Starbucks friends when I meet them, and in a little Italian restaurant where I go, and there's a bunch of elder people, and elder, they're really only a few years older than I, but they constantly talk about, well, surgery, it's the only thing that can do. We tried everything else. And I ask 2 or 3 questions, not being a doctor at all, just being somebody who is more alternative orientated. And whatever I ask, whether they tried this or this, they go, oh, no, that wouldn't help. You don't understand. My problem is huge. And my doctor said, and operation. Shed some light on of what people should do who have pain before they go under the knife, so that they can eliminate that, maybe the knife is needed. But then again, based on talking to you, it looks like a lots of time it isn't, because you have even told me that you had a patient who was 8 times surgery, things got worse after every surgery, and then you guys were able to help him. So you probably could have helped him better without the surgery. It would have been less damage done. And again, not to say that sometimes a surgery might not be needed. I'm not saying that either, and I couldn't. I'm not a doctor. But the point is, tell us what we people should do before we go under the knife.
Well, first of all, I just want to talk about some cases I've had where people have had problems with surgery. For example, back surgery. One of my patients asked the surgeon to guarantee his surgery. What guarantees do I have that I'm going to get better? And the surgeon told him, what I've seen in my experience, he told him exactly what I see in my experience. He said 1/3 of people get better, 1/3 of people get worse, and 1/3 of the people get the same. And the patient said, well, I only have a 1 in 3 chance of getting better. Let me try something else.
Right.
The other thing is that I've seen is surgery is risky. When you sign that form, the waiver for surgery, it says you can die. I've had 2 patients die, and these surgeries were done. These are spinal surgeries done by the top surgeon, and one was the top surgeon in Dallas, and one was the top surgeon in Fort Worth. And the surgery was a brilliant success, but they died from blood clots. I've had patients who had staph infections after surgery, after spinal surgery.
After successful surgery, right? That's where the saying comes, operation successful, patient dead, right? I'm not trying to make fun of your profession, no pun intended.
Well, these are just risks. They don't happen very often, but I've seen, I've been in practice for 30 years, and I've just seen these things, and it kind of scares me. And if you see,
let's talk about the dying thing. Let's talk about if the surgery, you don't die, but the betterment or the not betterment or the slightly because of it a lifestyle of being handicapped thereafter, because it doesn't look like God, if there is such a thing. I'm not trying to go into that direction, but I don't think we were created with a deficiency of morphium, or we were created with 3 too many bones, so they have to be taken out. Yeah, I just don't think we were created that way.
Right. And what we do is we try to prevent these surgeries. Like you mentioned before, you try to do surgery. Sometimes they need surgery and it's the absolute last resort, but we try to prevent it by doing. We try to do medications. We try to do, for example, for a spinal injury, we'll do bracing. We'll do physical therapy. We'll do electrical stimulation, ultrasound, decompression. We'll do exercising to build up the muscles. We can do. We've got MDs. We also have chiropractors. We can do chiropractic to help the patient.
And I got that. Without trying to cut you off here, Dr. Wolski, give us a little bit of a dialogue, if you will. So, what I should say to the doctor to the surgeon who wants to take me under the knife? What hard question shall I ask him, which might then, and then I'm going to make up my own mind, but what question shall I ask him so that I may go, oops, you told me already one. 1/3 gets better, 1/3 gets worse, 1/3 stays the same. Well, that's a 30% potential improvement a 30% potential getting worse and only 1/3 of staying the same, so why go under the knife? And again, for some that may be okay, but what hard question should we ask?
Well, I like that question. What guarantees do I have?
Okay.
And that was for a lumbar spinal surgery. It's not all surgeries that have those kind of risks. I'd also ask, what are the risks of anesthesia? I had one patient that went into a 30-day coma just from the anesthesia. Before she even had the surgery. It was like a complication of the anesthesia. That happens to 1 in 10,000 people.
Mm-hmm.
I'd ask, the patient should ask, what are the chances of getting a staph infection? Staph infections are rampant in a lot of these hospitals, and because they do surgery there. What is a staph
infection exactly?
Staph infection it's a methicillin-resistant Staph aureus infection. Is a bacterial infection that is resistant to almost all antibiotics. To treat it, it won't respond to antibiotics. You have to go in the hospital. You usually have to get a shunt put in and get intravenous antibiotics for 2 to 6 weeks to clear the infection up. Okay. It's just a very bad infection that's resistant to all antibiotics, or most antibiotics.
Got it. Let me ask you, is there also such a thing like, okay, you do the surgery, and let's just say it falls under the category of betterment, Mr. Surgeon. Now, how long will the betterment last? Is it permanent betterment, or will it again somehow, creep back? Would that be a question for some type of surgeries?
For neck and back surgery, for example, say if the patient gets a fusion, a lot of times several years later, the disc above or below the fusion may fail, just because of the mechanics involved. So there are long-term complications. The patients can get accelerated arthritis. So with spinal surgery, there are complications that are long-term.
I see. So the complications are, once the surgery is done, the complications are long-term, even if the surgery was considered a success?
Correct. There's a risk of like I said, the disc below and disc above the fusion blowing out later.
Okay. Okay. So yeah, all right. So basically, did you personally ever have a case with, because I know that you're not exactly having a small enterprise there, you're really seeing lots of patients, and they're coming from all over the United States. You put them up in hotels and you treat them. It's a long-term relationship, and you send them home, basically well, to a very high degree. Now, have you ever seen where you need to say, that's it, you got to go under the knife? And if you did, in terms of percentage, more or less, how often is that?
It's very individualized. If a patient has a giant extruded disc pressing on a nerve, and we've tried, say, 6 months of therapy and conservative treatment, and they're still having screaming pain, or if their arm or leg is shriveling up because of that pinched nerve, or sometimes I'll recommend surgery for a situation like that where they have a large herniated disc and it's just not responsive to anything else.
I see. So what I hear here is that you really haven't sent a patient to surgery right off the bat. Coming in, examination, you got to go to surgery. It's kind of go, let's work, because the very worst there is, it doesn't respond.
Well, there's a lot of evidence that says, there's a lot of data, scientific data that says you should try therapy because a lot of times that works and it avoids a risky surgery.
Now let's assume surgery needs to happen, as you said, 4, 5, 6 months, whatever it is, and the whole thing just, under professional people like you just doesn't respond. Will the fact that the person had therapy and what all the treatments you give him, the injections, the this, the that, all this, because I'm sure you worked on everything, and he now still needs to go to surgery, will that make the surgery potentially better, easier, succeedable done without the therapy before for a few months?
Well, the patient will be in a lot better condition. We do a lot of reconditioning and strengthening exercises. So the patient will be, so after the surgery, they won't be as deconditioned after the surgery. So we condition them before the surgery to build up their strength and endurance so they won't have such a hard time in the post-operative therapy phase.
And that's powerful because very obviously we know that lots of people, they start getting ill for different reasons in the post-operative because their body is so weakened, which a surgery is what it does. You need to lay, elder people get easier, the harmonium, all kinds of things because of all that. So what you're saying is they're so much better prepared, mentally and physically, that they will kind of like, weather that whole thing much easier.
Yes, that's exactly right. The therapy before the surgery will improve their strength and endurance and build up their core body muscles and make the post-operative phase a lot easier for them.
So basically, it looks to me that hands off, I couldn't think of a reason, no matter whether the doctor says surgery or not, that you don't first go through somebody like you, do the variety of therapies, the variety of things, go through it. Chances are high that it works, and if not, you're so much better prepared for your surgery and will stand it so much easier. Sounds like a great deal to me. Thanks a lot, Dr. Wolski. Thanks a lot.
You're welcome.